To be honest, probably that I wouldn't be here in front of you, speaking to you, if Dr. Thierry De Coster was not existing. Because if I am speaking a little bit of my personal history and the one of my dad, the FroggMouth adventure as a father and son company really started one evening in Brussels in an event specially organized for us by Dr. Thierry De Coster to introduce to all the Belgium orthodontists the FroggMouth. And it is also by seeing the great success, the great interest that every doctor there was having for the FroggMouth that we were deciding to launch ourselves into this big adventure. We know that Belgium is a very functional country where we had a lot of functional leaders, and Thierry De Coster is one of the biggest leaders of this wonderful country. He was the president of the SOBOR, the Association of Belgium Orthodontists, and also the president of the AOIF, the International Association of French-speaking Orthodontists. He is going to speak today about the rehabilitation with FroggMouth, how a simple treatment can treat a major issue. Thierry, c'est à toi.
Thank you very much for sharing my experience regarding the use and the efficiency of this re-education treatment tool or appliance. So the practice, my practice helped me to work with children 7-6. They have maxillary, but there is an open bite that is quite important. And for the so there is a new use which helped in order to see that the re-education or the rehabilitation made by a FroggMouth was easiest and helped also to have a better efficiency regarding the compared to the orthophonic conventional system. So when I see the patient at 8 years old, most of the time we notice that there is a transverse development, there is a maxillary development, and it is impossible to have a development to the adult's teeth. So what I do is I do an extension of the maxillary. It allows me, first of all, to have a functional development, to increase the functional volume, to reduce the endomaxillary size, and to improve the nasal breath, and to provide a prevention to and to snoring and apnea for children. It allows me also to favor the rehabilitation. It is after this maxillary rehabilitation that I realized the rehabilitation through the FroggMouth. Froggy. So the re-education helps in not only to improve the swallowing and the nasal breathing, but also to maintain the transversal dimension and to close an anterior open bite and to ensure stability. I use also the FroggMouth as part of the fixed appliance treatment, but also treatment with the liners. For example, for class 1, division 1, I consider when there is a severe overjet, so the children have difficulties to swallow, and in the same way, this re-education, because the tongue is projecting directly in this deep bite, and the child in this situation will throw his tongue or her tongue into this deep bite. So it is very important to re-educate simultaneously the swallowing and the overjet. Here I will show you the first case of what I mentioned a few minutes ago. And I'd like first of all to give you maxillary transversal development to have enough functional therapy and easier one. As you can see, we have a maxillary transversal effect. We do an extension of the maxillary, and in the meantime we start the re-education rehabilitation. But before the second step of the treatment, that means a few years later, we do the placement of fixed appliance, and then of course after that we go back to functional rehabilitation. through the froggy mouth. Here, in the second case, we had the dissemination of, we have here, so disjunction of the maxilla allows the rehabilitation froggy mouth, and then later on we use other appliances to avoid the overjet and to create an alignment. A third case, which is totally different, it is more about a skeletic phase 3. We can see an extension of the maxilla that is quite important, and then we have the appliance, and we apply appliance and froggy mouth all over the treatment. It is essential, of course, for me that the swallowing should be done the right way, and to keep that during adulthood, because it keeps the transverse dimension and also the upper maxillary volume. It is also a balance between centripetal and the centrifugal muscular forces, and the same way. And it helps also the bones and favors, of course, the nasal breathing. The tongue is an engine or motor of the maxillary development. During the development or during the growth, low posture and back position of the tongue can create obstruction and create apnea for children, but it can also skeletal hyperdiversions, like Harvard monkey experiments creating palate. It affects the palate. It creates hypotonia and adenoid faces and myopathies, and it is a vicious circle. We notice for the hypotonic patients, there's some myopathies. There is a historical study that led us to understand this phenomenon. Is the Harvard work. Harvard has put some closures or some plugs on the nostrils of monkeys, and that's where he noticed the importance of having kind of nostrils, and what humans or animals breathe by the mouth later on. So that's and of course Darwin talked about the change of the skeleton and the importance of the nostril and the projection of the tongue, and that tongue postures toward the posture forward, and that creates the anterior open bite. What are the consequences of a bad or a lack of lateral support? Of course, it is a transversal collapse. That means a reduction of the transversal dimension of the maxillary. We have a narrow palate and anatomical impossibility to adult swallowing. It is a fact that's the main consequence, as the palate is narrow, plus the more the swallowing is difficult, and this will favor the maxillary bite, and with a deep bite, with incisors, and with the low tongue posture, and that's mouth breathing, and it is a vicious circle of functional pathologies. So from the rehabilitation, orthophonic rehabilitation, in the past I used to use a lot the personal exercise. For example, I taught the patients, you twice a day, you drink sips of water, you smile and swallow to see how the tongue is, and you start the swallowing. It's a system that was efficient but required a certain motivation to set in place for patient. And the second is the way of correction are the orthophonists. We have to send them to the orthophonist twice, 3 times. So there are exercises that needs to be done at home also, and it's very dependent of the cooperation of the patient, even the personal relationship that the patient has with the practitioner. It can be efficient, of course, when there is a handicapped, for example, people who need them, who need active daily support, and of course for people who need that kind of overall coaching. What is the most frequent is I did the froggy mouth. So the froggy mouth is the advantage is break the labial ceiling, and without any effect, it reflects intuitive and without any effort. So it avoids the adult swallowing. So I think it doesn't require any effort for the patient. It is extremely easy to give that during the treatment or orthodontic treatment for the patient to be able to daily practice this exercise and to do it for the cerebral side and to have this neurological impregnation and to have this new reflex. And we've seen also the efficiency of the FroggMouth. It is also a way to it doesn't have any side effect to FroggMouth. There's no side FroggMouth. We can always, we can still use, there's no need to go to orthophonist, but it is a system that is specifically efficient. In orthodontics, and what is the most difficult to manage and what is the most complicated are the surgical relapses. You have to keep in mind that they still exist also in surgical orthodontics and in facial surgery. Sometimes the surgeon was in the past able to get stable. We saw in Deauville Congress a few weeks ago when friends showed us the relapse of deep bites due to surgeries. I will show you one which is personal to me, and here in this case we can see that there is a deep bite. This patient was sent to me from a colleague, and given the malformation, we can see that it wasn't sufficient. And there is also an open mouth, and there is open mouth. So the surgery does not allow to reduce these open bites. So the treatment went well. However, after 1 month of removal of the fixed appliance, we had a progressive reopening of the open bite with a slight open bite on the extraction side. So I suppose it is due to the tongue that creates this pressure to forward. And in the meantime, the patient wasn't really wearing this stabilizing device. So the situation worsened after relapse, and we saw an important open bite happening. And we are in a situation to restart another orthodontic treatment through aligners, displacing, of course, the teeth, which is important here. So what are the solutions for the open bites in orthodontics? We have some solutions, and we have therapeutic means. It is either to risk of forced mechanical closure of open bites traditionally, but sometimes you put elastics inside enough to avoid these open bites. But if we do not deal with the dysfunctional problem, the tongue moves itself. So there is the ingression and digression of by the elastic, and that those movements can be dangerous for the root resorption. There was frequent resorptions. Another solution is to close the open bites and to include what I do usually, that's what I do currently, is to include a treatment of a functional therapy. That means currently 3 FroggMouth. Most of the time it's FroggMouth. And from that side, we reduce this interior open bite, and we reduce also not to have this lingual frenium, and this frenium that affects the labial. We have a third path that we use. We use the aligners as therapeutic mean, but it is a passive closure, because the aligners have this advantage, is that they protect the teeth from the effect of the tongue, because there is no direct contact with the tooth. However, since they have a dual plasticity upper, they generate an aggression, posterior aggression. We can see that with all the patients. We saw it with we see to the patient, we can see very quickly on the right an aggression that is taking place on the molar, and it is generalized within all the patients who are using these aligners. It was considered as a disadvantage, but for our case, it is an advantage because it allows us to easily make the closure. Here you have a case which is more important and which is being treated, and you can see here the open bite is closing, and it is a superiority of the aligners compared to the closing of the open bites, compared to the fixed that doesn't prevent solution. In conclusion, I would say that in orthodontics, we always considered that one nail drives out another, and that the new techniques, a new method must systematically make disappear all the former old-fashioned procedures and methods. I do not agree with this statement and action, but we find it quite present. I think indeed that we enrich ourselves with the new equipment, appliance, tools, devices that help us to cater for the needs of unique cases and patients. And in this, the FroggMouth is an ally, precious ally that help us to manage simply and more practical for the patient, the problem of the patient, the swallowing, the chewing, but also the stability or the imbalance at the transversal, but also the vertical side. So I think that the FroggMouth can be an excellent, I have it in my arsenal and I use it on a daily basis for my patient. Thank you very much for your attention.
Thank you very much, Dr. Thierry De Coster, for this wonderful lecture. As some of you have maybe noticed, Thierry could not attend this event in live, so we were making a pre-record together. It's what we are seeing, but at least the good news with the pre-record is that it will be available in replay with many other lectures on the VFairs platforms.